everyone in Ballard Conference Center and online. Thank you so much for joining us today for Foundations of Global Health. I am Alexa Smith, and I am the Educational Exchange and Event Program Manager with the Office of International Programs. Before we get started, I would not be me if I didn't make a plug to remind you that today is the last day to vote. So if you have not gotten out and cast your ballot, please make sure you get that done today before 7 o'clock when the polls close. All right. Just a little bit about Foundations of Global Health. Global health is an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions, involves many disciplines within and beyond the health sciences, and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. And that definition is from the Consortium of Universities for Global Health. Global health is a varied and rich discipline to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world, this ongoing programming through the Office of International Programs is designed to feature those in our KUMC community engaged in the field of global health. KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Presenters will share their personal journeys, educational backgrounds, mentors, books, and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and even the heartbreaks. This series is meant to provide a platform for both presenters and participants to participate in conversations while developing foundational knowledge and exploring best practices for engagement in the discipline of global health. Our next presentation in the Partnering to Solve the New Trauma Epidemic series will be on Tuesday, December 3rd. So we hope you will join us again then. All right. Our speaker for today is Dr. Archie Heddings. Dr. Heddings is a practicing orthopedic surgeon in the University of Kansas Health System. He is also director of an international orthopedic trauma fellowship that focuses on alleviating disparities in trauma care throughout Africa. Without further ado, Dr. Archie Heddings.
Alrighty, I'm not Dr. Archie Heddings, but he will be coming up here in just a couple minutes. And so my name is Megan Lemons. I'm one of the medical students, part of the African Trauma Initiative here at KU. And I'm here to just kind of give us a very basic introduction to today's lecture topic and just really reiterate the mission of ATI. So to start things off, it's really important to understand the impact that trauma has on millions of people around the world. As we all know, trauma causes significant mortality. In fact, the number of people who die from traumatic injuries outnumbers that of people who die from HIV, malaria, and tuberculosis combined. Each year, approximately 5.8 million people die due to trauma, with more than 93% of those deaths occurring in low to middle income countries. And so this is a very significant issue. And unfortunately, it does not affect communities around the world the same. And that is something that our group, the African Trauma Initiative, is really passionate about doing something about. So trauma also causes significant morbidity. As you can see here on this chart, the number of people who experience disability-adjusted life years resulting from traumatic injury outnumbers that of cancer, ischemic heart disease, and major causes of infection around the world. And so why is that, you might be asking? So trauma tends to affect younger people. That's not to say it doesn't affect older individuals, but by and large, trauma is a young person's disease. And so when a person has a traumatic injury, they have more of their life to live than maybe someone who's older and has been diagnosed with cancer or ischemic heart disease. Not to dismiss the importance of those, but just understanding the impact and the lifelong effect that trauma can have on people's lives. And so research has shown that the vast majority of trauma cases are handled by orthopedic surgeons, accounting to about 64% of trauma cases every year. 26% are handled by neurosurgery on average, About 7% of trauma cases are treated by general surgeons, and the remaining 3% are treated by other surgical specialties. And so this graphic is really just highlighting the fact that orthopedics carries a tremendous trauma burden, and that is something that our group, again, is really passionate about, supporting orthopedic trauma organizations in low to middle income countries who need extra support in order to treat more patients. And so it's important to understand this bottleneck effect that can happen when you do not have everything that you need in order to treat trauma patients and to meet the demand that there is for trauma care. And so the three big things that you need in order to have a successful trauma outcome is a well-trained surgical team, access to necessary equipment, and access to a well-designed trauma facility. And so if you're missing any of those three things, what you get as a result of that is this bottleneck effect. And so ideally, we want patients to be able to pass through this funnel. When they have a traumatic injury happen, we want it to be treated as soon as possible to provide them the best long-term outcomes possible. But what happens if you're missing any of those three things I previously mentioned is you lose patience to this system. And as a result, many patients don't make it through the system in time and experience unnecessary mortality and morbidity as a result of that. And interestingly enough, the acuity of a patient's injury has a significant effect on whether or not they make it through the healthcare system in time to treat their injury and to maximize their long-term outcomes, in that people with high acuity injuries are the ones that are most likely to be treated, while the lower acuity injuries are the people who most likely have to wait. And in waiting for care, they may die. They may die from their injury, or they may ultimately develop a disability that they have to live with for the rest of their life. And so this has a very, very big impact on millions of people's lives around the world. And so one way to think about trauma is you can think about trauma as being a surgical disease. And some consider surgery to be the neglected stepchild of global health. And what do I mean by that? So research has found that major financiers of public health do not regard surgical disease as a priority in comparison to other communicable diseases that you often hear about on the news. Surgical disease is among the top 15 causes of disability worldwide and also accounts for up to 15% of total disability-adjusted life years lost every year. So it has a massive impact, again, on millions of people around the world, particularly those in low to middle income countries. International health programs have been very focused on communicable diseases like HIV and AIDS for the past several decades. And of course, while those are incredibly important, as a result of more of the focus being on those diseases, trauma hasn't gotten the same amount of attention. Most surgical pathologies are not transmissible, they're not infectious, and as a result of that, they're typically not ranked to be public health priorities in comparison to other diseases. And so it's really important to understand that even minor pathologies, if they're left untreated, they can become lethal. They can leave people disabled for the rest of their life. And even things like congenital abnormalities that can be fixed with a simple surgery can remain lifelong afflictions. And so as of today, trauma surgery and global health efforts are not able to meet the demand that there is for trauma care. So many patients are impacted by trauma, and many of these patients are unable to receive the care that they need. In fact, 5 billion people do not have access to safe and affordable surgical care. In low to middle income countries, approximately 90% of people lack access to basic surgical care. Of the 313 million surgical procedures done every year, only 6% of those occur in the poorest countries, and those countries make up roughly a third of the world's population. And it's been estimated that 143 million additional procedures are needed in low to middle income countries every year to prevent tremendous amounts of disability and mortality within these communities. And so tying all of this into the topic of today's lecture, it's important to just know that there's many different types of global health initiatives, and they all address this need for healthcare in different ways. For example, there's short-term medical missions. These typically last a few days to a few weeks, and they typically focus on more acute things. And so these provide surgery, dental care, vaccinations that are very acute in nature. and are often carried out by small teams in response to things like natural disasters, conflict, things of that nature. There's also long-term medical missions that extend over months to years and are often carried out by healthcare organizations and non-government organizations like nonprofits. And these really aim to strengthen the local healthcare infrastructure in remote and underserved areas in order to provide sustainable healthcare for long periods of time in these communities. There's surgical missions that, as the name implies, are dedicated to performing specific procedures, things like cleft palate repair, cataract removal, even orthopedic surgeries. These require highly skilled team and also specialized equipment, so this can require a lot of resources in order to do surgical missions. Dental missions provide dental care predominantly in areas that either have very minimal access to dental care or lack it, period. There's emergency response missions that are typically organized in response to natural disasters, conflicts, very sudden things in which there's a very big need for care. There's public health missions where local public health professionals are educated and trained, and this really just allows for them to improve the health of their communities and, again, provide sustainable health care. There's also educational and training missions that are very similar to public health missions and really focus on the community as a whole and educating the health professionals within that community. There's even mental health missions that are focused on providing psychological and mental health services in areas that have experienced conflict and things of that nature. There's even specialized clinics like HIV/AIDS clinics that aim to vaccinate people against certain diseases and very, very specific specialized medical issues. And then the last thing on my slide here is faith-based medical missions. I feel like that is probably what most people hear about, but it's important to acknowledge that not all global health initiatives have religious associations or backgrounds, like ATI. We are not religiously based, and there are a lot of medical missions that don't have religious affiliation. And so, really just reiterating the mission of our organization, the African Trauma Initiative, our primary mission is to partner with African teaching institutions, medical companies, nonprofits, government institutions to develop self-sustaining orthopedic trauma care hospitals in communities in need of this type of medical care. We are aiming to alleviate the current trauma burden on African public hospitals so that they can treat both low acuity and high acuity traumatic injuries that may not be treated as they have such a high resource demand and burden placed upon them. We want to do something about that. And we also strive to inspire the next generation of healthcare providers to continue this work with the ultimate goal of ridding the world of healthcare inequities. And so with all of that said, I'm done with my spiel. And so I'm going to welcome up Dr. Archie Heddings, who is the leader of the African Trauma Initiative.
Thank you, Megan. Great job. So, if you may not realize it, but you're on the cutting edge of something. And what you're on the cutting edge of is you're on the cutting edge of how do we provide equitable treatment for people with surgical disease, focusing on trauma. But, and if you want to understand how to do that, and it's in the auspices of us reaching out, working transnationally to help people in need. And if you think about a lot of medical care, this has been worked out really good for things like vaccines or other types of infectious diseases. This has not been worked out very good for surgical disease. As Megan pointed out, the tremendous burden of surgical disease that's present and our lack of ability to treat it. So we're aware of this need, but we don't know how best to solve it. And so this is kind of a forum. We're presenting ideas, and a great place to do that is at an academic institution, and we're open to criticism, and we're looking for the best way to solve this. And if you look at the organizations that are involved in doing this type of work, it's faith organizations, it's humanitarian organizations, and it's academia. It's these three types of organizations. If we want to figure out how to do this, one of the best ways to do it is understand the past. So it's good to look back and see what's done in the past, what's worked, what's failed. in my own lifetime doing work overseas, I've seen things that just haven't gone that well. I've got an example of me doing something poorly. It's going to be very open with everybody today when I share this video. And I want to be cognizant of time because we've got to make sure our panel speaks. 12:18. Okay, thank you so much. So stop me at 12:30. So let's go. We're just going to step in the past. We're just going to look in the past. We're going to talk about the history of mission work, reaching out overseas to help, or transnationally to help people in need medically. And then hopefully I'm going to end with something that unites everybody. It's great to do that on election day too, in a very polarized nation, but we're going to end with something that I think everybody's going to look at it and say, oh, that's me. That is me. So, but if we look at international health timeline, let's look at the first hospitals. The first hospitals, these were termed Xenodokia. And the first one, you can check me on this, but what I found, it was in Rome. It was the first hospital. These were the first hospitals. They were made by Christians who wanted to provide care for aliens from other nations who were sick, basically. And they needed these hard structures to recover in. So these were formed, and they were quite popular throughout the Byzantine era. And then the term missions gets introduced by the Jesuits around the 16th century, and it refers to an expansion of the faith, but also with that occurred medical care. And then we have humanitarian organizations come into play with the development of the Red Cross in 1863. And then the League of Nations Health Organization, which later became the WHO in the 1920s, 1946. And some of these secular humanitarian organizations formed after conflicts, because what happened with World War I and World War II is these weapons of mass destruction developed, and the amount of battlefield injured was just tremendous, that overwhelmed the healthcare systems. And these people who formed like the League of Nations Health Organization, the Red Cross, they looked at all this suffering, all these people that needed care, and so they formed these organizations to reach out to all these people that were injured in conflict. In the 20th century, about the 1960s, you see some formalized Muslim humanitarian medical care come into being. The Aga Khan and the Islamic Association of North America. 1971, another humanitarian organization was formed. Doctors Without Borders were all the quintessential medical missions, if you will, organization. And then, look how recent this is. 1980s, the American College of Surgeons begins to focus on global health. That's really not that long ago. So there are success and there are failures of these. So the success of the early Christian hospitals, it's really interesting. I guess the Roman Empire wasn't too interested in caring for the sick. They didn't think it was something that was that important, I guess. But when Christians came along, they thought this was important, and it, as you can imagine, it helped with their popularity. They were caring for the poor. They were caring for the sick. They were touching the untouchables. And there was one of the emperors, Roman Emperor Julian, even noticed, he made comment of this, that it was amazing that where Christians seemed to be at, that the poor were taken care of and the sick were cared for. And this was later something that he then, if I'm correct in my history, that he then helped implement, some more of these type of public works that the Christians were doing. Go out a little bit further when you look at early Christian mission work that occurred in Africa, that occurred alongside colonialists. You'll see that it was at a missionary hospital, the Church Missionary Society Hospital at Mingo, February 11th, 1901, that the first published description of sleeping sickness cases occurred. And it was through understanding that they were then able to implement different public health programs that saved thousands of lives. So there's something good that came out of...
in progress.
Sorry. There's something good. All I'm saying is there's something good that came out of this mission work. And the thing, when you look, in particular when you look at Africa, you had imperialists coming in, and then at the same time you had people coming in that were doing mission work. And it's interesting, they didn't both necessarily have the same goals. In fact, if you look, the people that were going in for purely reasons of compassion, a lot of times the colonialists did not want them practicing in their area. I think, but at the same time, there was medicine that came in through the colonialists that was there primarily to benefit themselves. And I think that's an example of healthcare that's done. You know, you're helping out, in particularly infectious disease, you're helping out a local group in treating an infectious disease, but the end goal is it's because you don't want the infectious disease yourself, right? There's good that comes out of that, but the motive necessarily isn't the best. A good example of a recent type of faith-based organization with respect to delivering surgical care is the Cure Hospitals. And this Cure Hospital, Dr. Abebe, Lori, and I actually visited when we were in Addis Ababa. And it's where Dr. Nitsanet, who's the chairperson of the orthopedic department in Abbott that we work with, it's where she trained at. But they do a lot of good children's surgery there for treating different types of deformities and things like that. So these are examples of successes. Secular, humanitarian, global successes, I think we're all very familiar with this. They're very numerous. If you go to the WHO website, they've just got a section on things that they consider successes. 1980 smallpox eradication. I just picked out a few. 1983, HIV was discovered. Then after that, treatments were discovered. Then after that, they were implemented. I don't think anybody would argue that these things are good. 2014, you have the Ebola outbreak with a successful international response. 2021, they announced a malaria vaccine for children. So there's examples of successes both on the faith-based side. There's examples of successes on the humanitarian side. Here's some examples of secular humanitarian global health success on short-term mission trips. And some of you are familiar with these or have heard of these, Operation Smile or Smile Train, and then Mercy Ships, which the U.S. Navy has, right? Which is it's a traveling overseas hospital, and they deliver surgical care. You can criticize all of these. All of these things can be criticized. If you look at each of these, whether faith-based, whether humanitarian, whether academic, there's ways to criticize these. There's ways things can be done better. But I'm focusing on the good, at least first in particular, because I think it's important to note that good can be done. And I don't think our response needs to be, things have been done bad by each of these, and therefore we should walk away from this problem. That's not the answer. There's a problem. People are dying and becoming disabled. We need to help come up with a solution. So when international health goes wrong, there's a good article. I have it at the end of my references on this talk. And the author's name is Welling, and he just talks about the 7 sins of international health. We'll go through these quickly. You don't want to leave a mess behind, right? A good example of that is a sick or dying patient or a patient that has complications. If you're going to go in and do surgery, you need to do it so you minimize your risk of complications. Failing to match technology to local needs and abilities. Don't go in with technology to treat or do something, and then once you leave, that place doesn't have the technology to follow or help the patient. Failure of non-governmental organizations to cooperate. Boy, you'll see every nonprofit needs money. They're all reaching out to the same donors, and that can sometimes lead to them not working together. We have to work past that, all right? The same is true with working with military organizations. Some of you know I was former military. There's some good that can come out of working with the military. And I think if it's done wisely, using those resources can be used to help people. Failing to have a follow-up plan, allowing politics, training, or other distracting goals to trump service. That's one of the big criticisms of academic models is you're just sending your students over here to train. You're not sending them over here to benefit us. Going where we're not wanted or needed. You may like the surgery you do, and you may want to do it in some foreign land, but if they don't need it, don't force it upon them to go over there and do it. Particularly don't take their operating room time to do a surgery that they really don't need, and then that blocks them from doing the surgeries that they need to do. And then doing the right thing for the wrong reason. This was something that I thought it was funny, but it came from The Onion, but It just says a 6-day visit to rural Africa village completely changes woman's Facebook profile picture. So, right, it's just a funny, so anyway, there along the lines of being a poor guest, I just have my own confessions here, and I'll show you an example on how you can be a poor guest sometimes and not even pick it up. So I knew that this interaction went bad, but until I went back over the video, I just didn't realize how bad it went and how it started to go bad before I even realized it. So I'm gonna play you this video here. So we'll just go through it first, and then I want to go through it again. So just watch this. Let's see, where's my cursor? Here we go. So the context is I'm being driven into the hospital. And there's one street that I just like for whatever reason. It just stands out to me as like, this is the classic African street. And there's some things there that I see that I like. But I want to film it. So I'm going to take my cell phone out. I want to film this. I'm going to teach you what not to do. I want to teach you all what not to do.
The pictures I took of this road yesterday, I took pictures, and they're really beautiful.
I just hate hearing myself talk.
And I didn't realize it until I looked at the picture last night.
All right. At that point, the person that was driving me literally jumped across his seat and swatted my phone out of my hand. So it doesn't seem like it's that big a deal, but for him, it was a big deal. Yeah, just this is a stupid thing. But it's, and it was a contingent from KU that went. And one of the staff from the radiology department went. He did something almost the same day, very similar. But he was out in a marketplace, not in a car. And he almost got accosted with his cell phone when he was filming people that didn't want to be filmed. But let's go through this again. If this doesn't work out great, I apologize for my editing, but let's go through this again.
The pictures
Look at that look. Like nothing bad has happened yet. Yeah, right. You think I would have noticed that? No. I just kept going. I'm being very open here. But for my students, don't make this mistake, right? Don't make this mistake. So let's go on a little bit more.
yesterday, I took pictures, and they're really beautiful.
Beautiful pictures. Boy,
And I didn't realize it until I looked at the picture last night.
One, two, three. Let's introduce our panelists, okay? All right. It's just a point of, I went there with the best intentions, right? And I wanted some people to see some things I saw, and I think there's a lot of beauty there, particularly the two kids playing, the mother with their daughters. I love these things. But boy, I was being offensive. Things you have to be aware of, and medical care is the same. You have to be so sensitive into the way you deliver it. So without further ado, let's bring in our panel. Dr. Abebe, who is on staff here, one of the best people I know, who's part of the African Trauma Initiative. He's our chief of staff. He's going to join us for the panel discussion. Why don't we come up here at this table? Dr. Beza is our most current fellow in trauma. Cameron King is going to be moderating. And let's see, can I pull up our Zoom audience and see if Dr. Kinda made it?
I'm not sure if we have access to the Zoom. It just says share.
Is Dr. Kinda on, Alexa? Patrick, are you there?
Is it Disu?
And Adisu. Okay, Patrick was going to try and make it, but it's his operative day. So the thing about Dr. Kinda, he was our fellow last year, and Dr. Kinda works at a mission hospital. Okay. Okay, all right, he couldn't make it. He was going to try. Okay. Oh, I have one more.
Hey, DC, he misses.
Click past that slide.
Okay. Oh, I gotta share the screen again.
Yeah, share that. Because this comes down to the common thread.
Let's see.
Yeah. The common thread, and it's why you're all here. I would bet you, if you think about this, this is why everybody's here. The common thread. Yeah. And the common thread is basically you're doing some compassionate act, right, transnationally, and you're doing it with an appeal that it's somehow related to the transcendent, something bigger than you. If you're honest with yourself, that's why you're doing this, right? You're here because you think helping other people, it's the right thing to do. And the conclusion there is it's related to something transcendent. And that's why I think you see faith-based organizations involved. That's why you see humanitarian organizations involved and academia, because that's what drives all three of those types of institutions. Okay, I don't want to take too much time, because I want to get time to hear from Dr. Abebe and Dr. Beza in the DC.
You can tell we're obviously well versed in all of the technical parts of it all.
Okay.
I'll go ahead and start with this. My name's Cameron King. I'm one of the second years who works with Dr. Heddings, as well as Joey and Megan. And I have the pleasure of being the moderator for the panelists and the discussion. So if you guys want, we'll go ahead and you guys can introduce yourselves, and then we'll start with some of the questions. So Dr. Beza, do you want to start?
My name is Dr. Beza. I'm from Abbott Hospital. I just started fellowship under Dr. Heddings in KMC. So.
Yeah, my name is Abebe. I'm one of the internal medicine attending here at KU. I'm involved in multiple activities. I'm currently Vice Chair of Undergraduate Medical Education. I also work as the core faculty in the Department of Medicine, and I'm a member of the Kansas Board of Healing Arts, and I'm involved in a lot of medical student and residency initiatives. And I'm glad to say I'm part of IOTC thanks to Dr. Heddings, the most altruistic person I know in the world.
Alrighty. Well, so I'm going to go ahead and start here. Can each of you kind of give me a little bit of a share with the group about your understanding about the history of some of the medical missions that you've been on and the evolutions of that, and how some of the interventions that you've seen change over time with the medical missions that you've been on?
Medical mission, I came to understand about that term way back when I was in Ethiopia, just high school, and there was a group of cataract surgeries that came up, and I know someone in the neighbors were talking about going to get that surgery. That's when I came to know about medical mission at that time. But what was interesting at that time was they were not able to be picked up because they told them that there were people who have more severe disease. It was a sort of disappointment at that time. And the same holds true for someone I knew who had a cardiac problem, and they were having folks to get surgery, and they were not selected because the people who came in didn't have the manpower to take care of all the people. So you would be probably coming in and doing 10. And I remember my disappointment at that time. I was like, how did you come to this? Not being able to do all this. And I think this is one of the drives that propelled me to become a physician eventually. And moving forward, when we were in medical school, we didn't have enough teachers to begin with. So we have physicians coming from Canada, from Cuba. So it's kind of an extension of what mission to care for the poor or the needy, if you will, by training physicians like ourselves. And they would, during the off hours, there were doctors from Cuba, Canada, and England. They would come in and they would probably help the poor, if you will, at their own time. and after going to medical school and practicing, I hear all about medical missions, people coming in doing here and there, and I didn't feel like it was one. It's kind of, I call it like a parachute or a helicopter kind of thing. You know, they come in, they do their thing, and they go out. It doesn't leave a whole lot of impact both for the people and for the health personnel that actually care for the patients that they face, if you will. And moving forward, obviously, you know, I came to the U.S. and saw different kind of organizations and keep in contact with a lot of folks. And I'll be very honest with you. You know, we do things at random. We don't have kind of a very organized way of carrying out mission back in Ethiopia. And I was involved in medical missions through people that I know. But the overarching thing that I realized was all this were just interventions that were just come and go, come and go, come and go, and didn't feel like I didn't even have the desire to be involved, to be honest with you. And when I came to know Dr. Heddings, and I knew that he started this actually opened my eyes, because looking at the mission, hey, let's train physicians. Yeah, let's train fellows. Oh, by the way, let's equip the hospital that they work with, because I know how dire things are. It's funny. I go there to visit families, and man, every time I don't like people to know that I'm a physician for many reasons, and I guess just as a regular person, and I know where to go, and I know where to pick. I know who the physicians are, and sometimes I come to realize, well, if I was just a random person, I would be in trouble. Even for me, who knows stuff, it was very difficult. So moving forward again, so it was really great to know that we equip the physicians, and eventually, if things align, we'd be able to find, build a hospital. So I'm more into the kind of setup that Dr. Heddings is leading on. I'm not saying it's bad to have missions that just come on and do stuff. And I like a kind of mission where it's not based on religion, politics, and more into kind of helping humans for who they are. And I feel like Dr. Hedding is leading an organization that aims to satisfy that. I could go on and on, tell you different examples, but this is my experience.
Okay, thank you. I have also some experiences in regards to these medical missions, and to my understanding, a medical mission is just to give, with a group of people or non-governmental organization, this will provide medical care to those who are underserved. So whenever I think of medical mission, I think this. And there have been these short-term medical missions which have been done in my hospital when I was a resident, and it was a good experience, because at that time the impact was quick, and we got to see what what the medical care is in other places, and we got to learn something about it. But if you think the impact those people came and provide, it's very little, and it was difficult after they go back home to follow these patients. One thing, you need to be equipped to manage complications if it happens, and even we have those occasions that they did the operation, they left home, and there are a couple of people who got complications, and we were not able to give them the care that the missionaries should have given them. So even if it has a good, impact, like it's better than not having anything, especially when think of my country. And there is also this mission. Now I got to get to experience with Dr. Heddings and ATIT in general, and it's a long-term mission, and it has its own cons. Like, it's going to take a longer time. It will drain the money, your time, family, but it has a long-term. Also pros, like it's going to build a hospital. It's going to teach physicians, and kind of have the time to learn the culture of the people that you're going to give the medical care, and it's going to be sustainable in some way. You got to be, because you have the person, the equipment, and the hospital to treat and manage the patient. So I'm kind of in that perspective right now, and I mean, it's a good opportunity to be part of this ATI, and I'm just consumed in it. So that's my experience.
I just wanted to make sure, Adisu, on the chat, did you have anything to add about that question about like what you knew about the medical missions and just kind of the history of it and how it's kind of impacting you where you're at? If you can unmute, I just wanted to make sure if you had anything to add, that's fine if you don't. Okay. I'll go on to our next question here. Dr. Heddings hit on a really good point about the development of medical missions with technology and things like that. Can you two speak on how this organization is kind of combating the issue of changing technologies and kind of developing that in Africa, how they're trying to kind of close that gap with the technology differences between countries?
I mean, in my experience, I'm an orthopedic surgeon there. I have my own residency program which I run, and I got to see what you guys are doing in your clinic and also in your wards, your floor, and also in the OR. And to be honest, the place where I work, I didn't even have 1/3 of the equipment they got on the operating room, and also the team they have. It's not like even to compare. And in outpatient clinic, the patient is the one, in your setups, the patient is the one who sits in the room, and you got to make the rounds and have their own privacy, and you got to take them as much as they need it. But back home in outpatient clinic, it's like a lot of people in a single room, and we work. It's difficult, to examine patients and to even to listen to them. So it's not even to compare. So I came here. I've been here like for about 1 month now. I got to see a lot of stuff, a lot of technologies that I can. It would be so nice to have back home, and it's hell of an experience, and I'm dedicating myself for this mission too. Yeah.
Give you anything to add to that, Dr. Bebe?
I'm not a surgeon, so.
Adisu, I just wanted to check, are you able to unmute now?
Sure.
Oh, good.
Good afternoon, everybody. Can you hear me?
Yes, sir. We can hear you good.
Good luck with your election, and let's to add on some of the points.
Thanks, Adisu.
Okay. So, as all of my colleagues tried to explain it, so almost it has its own pros and cons, but in most of the case, so the issue of these missions is, it's helpful for short term, it has short term outcome, but long term, you might not, even you will be mainly depending upon those missions to, satisfy your patients, but considering the patient load and the problem, it's almost, it's the iceberg for our problem. So you cannot try to cover all of the things. Most of the missions, they stay maybe 1 to 2 weeks in most of the case, and the issue is even they will not try to, put or left the equipment and the materials there for those persons who are in need. They bring it back from where they came. So it's overall, it has a short-term outcome, which is good, but it will not satisfy both the patients and also the physicians. Let's tell you one example. One of the missions when we were like at not actually a resident, at a medical school, they came and the total hip replacement was done as a mission. They came from USA. Then meanwhile, I think when I tried to recognize what happened, what went wrong at that moment, it seems like that the antiversion was not good, and the patient had a complication of dislocation. Then they went, and the dislocation happened after the missionaries went back to their home. So there was no one in that space which can handle the problem. So, you know, it will give you only a short-term outcome. Otherwise, long-term, you cannot, you know, help a lot, both physicians and also the community. Overall, all of the, you know, the missionaries, everyone reached here because of, you know, which starts from a small and reaching to the, you know, a bigger steps. So all of them, they have helped, but it will not, you know, reach into the expected outcome.
Absolutely. Thank you so much for that perspective, Adisu. We've had a lot of discussion today about the sustainability, the necessity to be sustainable on medical missions. For all of the students in here, in what capacity do you kind of advice that you can give to them on the ways that they can help us in this initiative of kind of the epidemic that we're talking about? Let's go specifically to the question. What ways can they help you guys kind of get to your goal for medical missions? What are ways that they can get involved and things like that?
One thing that this community can do is we have to understand what the mission is, and it's not going to happen very soon, but we have to believe it's going to happen at some time in the future. This is a long-term mission. It's going to work in the way train you got to build your human resource first, and who knows the culture, who understands the community, and then you have to keep them with some of the materials that's needed, and also they need also a place to work. So this is, I think, the mission of this ATI, and make it sustainable at the end. It has to be sustainable. You just don't leave it there. So this is a mission, and everyone should around here can help by, you know, at least talking about it and spreading the message. Something they can do. Yeah.
For sure.
I think to add to that, it's getting into the mindset of what it means to help others. First thing is understanding that you're going to be bringing a huge impact into the population that you're going to lead. And the first thing is first know what it means to be part of an organization that is going to train, equip, and build a hospital. And then you'll be the vehicle of information for your community, both at the KU Medical Center and in your individual community at home, if you will. The next step is recruiting people left and right to find either in helping directly or indirectly in financial means to help the first few steps. Everything, we always say in our country, egg walks and eventually becomes, walks on its own. So you will be part of an organization that eventually will be a model, in my view, to provide a sustainable care in underdeveloped nations. Think of it as doing a good thing while actually fostering your education, which is just caring for patients where you are, but going to underdeveloped world and bring an impactful change.
Okay. So I know a lot of the M2s will have to leave here soon for PBL. Do we have any questions in the room before I go on to the next one? Anything? You got one, Joey? What's your?
I have a question, yeah. So one of the things we do with the trauma fellowship here is we train
We'll do the
fellows,
microphone.
oh, I'm sorry. So one of the uses of the trauma fellowship here is that we train the fellows so they can go back and use some of this equipment back in their hometowns. How does sustainable care look like in terms of having equipment available to you back in where you're from?
Yeah. Does that make sense?
Yeah, yeah.
If you look at the models, so this is where I said we're on the cutting edge. How do we make global surgery work? And if you look at what's being written about this, the thought is these three groups, faith-based organizations, humanitarian organizations, and academia need to come together. Because the training really needs to be done by academia. And the openness that comes with humanitarian organizations serves everybody. Faith-based organizations some time ago actually moved away. Most of them moved away from making their medical work focused solely on proselytizing. So a lot of the Cure is a good example of that, I think. So, but if you need a constant source of cash in terms of bringing that cash into the system to maintain implants or to maintain care for people who can't pay for it, the best place to get that pool of money is from a faith-based organization. Academia is not great at that, but faith-based organizations aren't necessarily the best at doing research and training, if you think about that. So yeah, that's my brief answer to that question. But we're developing these models in terms of how do we solve this problem, and it seems to be bringing these three types of organizations together, which can be tricky, as you know, because they all have kind of different opinions on things.
I think piggybacking on Cure, what I liked about Cure was they have places where they make prosthetics actually right on the spot, which makes it the human power is there, the material is from there. I know this probably doesn't transcend into orthopedic implants and so forth, but I think if we give the government and organizations a model of that you can make this thing sustainable, you can channel money to organizations who actually make those implants, and maybe someone altruistic like Dr. Heddings may be part of that kind of organization. But I agree, like if you just send implants and they run out, it's probably not sustainable. But I think you have to also look at it from a perspective of trying to find initiatives from different organizations that can actually help with this kind of initiative.
And one thing that's actually been really exciting that we've gotten the opportunity to work through with Dr. Heddings and Abeza and Abebe is we have been formulating shipping containers to ship to Zambia and other places like that. So it's been exciting to be kind of integral in that part of composing what goes into those shipping containers. Lori and I were talking about it earlier about kind of looking at some of the actual medical equipment that goes into I think they're called sets, right? Yeah, the instrument sets that compose that. And again, as students, we have an opportunity to get involved with that, and that's been really exciting. I do want to make sure all the M2s have enough time to get to PBL. So if you guys, we'll go ahead and excuse you guys as M2s who want to make it there. As far as anyone else, will the panel be continuing after we have to go to PBL? Because
We can stay a little bit longer.
Okay.
Yeah, probably like 15 minutes longer.
Yeah. For those of you who do want to stay, you're more than welcome to. Unfortunately, I have to leave to PBL. But if you would like to stay and kind of encourage some of our panelists to answer more questions or find ways for you to get involved, you're more than happy to. And for everyone who came, thank you so much for coming here. We really appreciate you guys being willing to listen. So, and can we give a round of applause to all of our panelists?
Thank you all for taking the time to come. Thank you guys so much.
Yeah, absolutely. And Joey just reminded me too, for all of the M1s too, we're going to be looking for the next 3 students who are going to follow up in leadership for ATI for us. That's going to be tomorrow from 12 to 1, and it's in Orr Major 1037. It's in the email. If you guys look in the email. So if you guys want more information on ATI and IOTC, we'll be giving that to you guys then. So again, thanks you guys so much for coming to this lecture series. We appreciate y'all being here.
Thanks, Cameron.
Yeah, absolutely.
Okay.
Is this your phone?
Yes, that's mine.
Yes.
Any questions? Let's just open up for questions. Yeah. Here, let's pass this over.
Well, I'm not a med student. I'm an employee. But from just in hearing, and I so appreciate your hearts. In medical missions has always been something that's been very near and dear to my heart, even not as a medical student, but as a civilian, and being able to go and provide care in different places. And understanding how the 3 entities are kind of comprised, and understanding also that we need to figure out a way to break down those barriers to get those organizations to work together. What do you foresee as being kind of, if you could devise the perfect plan, what would that look like? And how can we as civilians even try to help support that? Or are there things that are within our ability to provide change? Can we do something to do that?
So, can you hear me, or do I need this? You need that. I need, okay. So, in a perfect world, we would match academic institutions in Europe and North America with academic institutions in low to middle income countries. They would intertwine their teaching, in terms of medically, and you would have this cross-pollination where basically an academic institution would send and receive students from their sister organization, and that would help develop the training because, like Dr. Beza said, he said he didn't even have one of my sets. Well, you can't train and learn how to do state-of-the-art surgery if you don't even have the sets. So unfortunately, they just have to come. But then in addition to that, you need to go over there. Our surgeons need to go over there because there's things that we can see in terms of like when it comes to equipment saying, oh, you want to use my arm? Actually, you're going to need this, this, and this. So it's not just, it really goes both ways. So that develops relationships and friendships, and that's just the glue that keeps this together. But then in terms of the funding mechanism, really humanitarian organizations and faith-based organizations, that's their call. It's just it's like this, we're not arguing about the importance of serving people who are suffering. It's something that just in those organizations, it's expected. We've identified a problem, there's people that are suffering and we can solve this issue. Help us out, give us financial resources. And so, and they partner, you would have, basically faith-based and humanitarian organizations that have a pot of money that would be able to sustain some of these needs until these societies become self-sustaining themselves. Because if you look at Ethiopia, the economic growth there is incredible. At some point, that will become a nation that doesn't need to rely on, donations. Their GDP, I think, was like 8%. It runs between 8 and 10 or 12. It's just tremendous. They're growing so quickly. So that would be an ideal model, I think. And I'm not the only one saying that. This is being written about in other academic journals.
I don't think I have anything different than what Dr. Hedding was saying, but to kind of reinforce that, it's always good to be involved in an organization which probably has a more sustainable form of care, if you will. It's good to have an organization that's able to channel money for small or short-term medical missions, but kind of making the community being aware of this kind of organizations that they are present, who are actually involved in teaching and having fellows coming in and sending equipment that actually help them. And if we find people like yourself who are going to be part of a group of people that are able to help procure funding and other forms of help, that would be the way to go.
I have a question right back there. Annie.
Could you just speak a little bit about the origin of ATI and how the whole thing got started, how the connections formed for where you guys choose to work, and just, I think I've missed how this all started.
So I started doing short-term mission work, and I went to Ethiopia. I spent 2 weeks there, and I operated with them for 2 weeks. And as I was leaving, one of the surgeons there, Dr. Solomon, just sat down with me in front of their whole department. Their whole department sat down with me, and he looked at me, and he looked me right in the eye, and he said, "We don't need more American surgeons to come here and operate." And then he said, teach us how to do what you're doing, and we can do this. And I don't know how many people they had said that to, but I said, okay. That whole trip was just a blunder. You got to see my video. I was just blundering. At least I was operating well. I guess the saving grace was at least I was operating well, because they said, just teach us how to do this. But so we became friends, and so that's how. And then we just started working together, back and forth, and we developed this fellowship. And then once the fellowship started going, when they came over here, when Dr. Abby and Dr. Solomon came over here and had the same realization that Dr. Beza did of, we have none of this. If you've never been to a place, like if you can imagine, they just saw Americans come in and break some equipment and do a surgery, and they thought, oh, that's all we need. And then, and they're working in a trauma center that is a hotel that's been converted to a trauma center. That's their world. And then all of a sudden they come here. They come here and they realize, whoa, we need a lot more to do this. So then we said, okay, what exactly do you need? And they said, we need equipment. And then so we said, okay, we're going to make that a component of this. We started ATI, and it was about equipping and educating. And then they went back to their country, and it was a horrible start, a horrible launch. And this is literally, I just bought a plane ticket and I flew out there. I said, should I come out and help you guys? They said, we don't even know. This is going really bad. And I won't say who, one of them was crying. They were just like, worst decision of my life. It was really, this is a very emotionally enriching thing. And so I just said, I'm just coming out there, Abby, I'm coming out there. I just bought a plane ticket. I didn't even know what I was doing. I got out there, and and they were coming out of a civil war, so all this stuff was going on. And then as we kind of were working through this, I looked at Abby and Adisu, and we all said, I don't know who came up with it, but I think I said, you guys need a hospital. And they said, yes, that's exactly what we need. And so then we put it all together, and we were like, oh, so this is really big. If this is going to work, it's not just doing surgery in a converted hotel with state-of-the-art equipment. It's doing surgery with well-trained surgeons with state-of-the-art equipment in a state-of-the-art hospital. Isn't that what you would want for your loved ones? And that's what they deserve as well. So that's, in a short description, that's how we got here. Yeah. Any other questions?
Thanks so much for taking the time to talk to us. I love hearing about how as students we can partner with you guys with fundraising and getting the word out and filling the containers to Zambia. Are there opportunities for trips as medical students, or is it more of like let's get the word out, let's build support, that kind of thing?
What do you think about trips, Dr. Baby? Yeah.
I think I would take it in two ways. One, it's a personal fulfillment going to being able to go to Ethiopia just at an early training, finding out kind of, I would call it propels you to do more on your part from enriching your own education, but also like when you're done, you want to be part of this organization. My feel is, I don't know how Dr. Heddings feels like. If someone, I know Ruth, by the way, she's one of my students who I coach. But I think if it's my way, I would like to have students be part of the trip, because it's just so eye-opening. There's nothing better than having a personal experience. Just nothing, like in everything, in person is better than anything. So if it's my way, I'll be happy to be part of a lead where we can help you guys go and be part of this trip. Instead of me going, actually, it's better if you go.
Yeah, it changes you. I mean, it does. Yeah, going for the right motive, or I would like all my students and all my residents to work overseas in a low to middle income country. That's my dream, that it's a rotation, that all American students that have been vetted get to experience. It's a funding issue, but I want to find a way that everybody could go. It may not be Ethiopia, because you can't just put everybody into one institution, but there's different we're working with Uganda now. We've been asked to work in Cameroon. So Uganda, Cameroon, with this mission. So Zambia, Ethiopia, there's place, if we can raise the money and build the endowment up, we can get students going. And it will make you a better physician. Absolutely convinced.
Make you a better human.
Yeah, agreed, 100%. Make you a better human. So, yeah.
And I think you also learn a new culture, a new everything. It just completely transforms you in ways that you've never imagined. The same way I've been transformed coming to the United States. It's both directions.
Also, if this thing happens and working place, there can be kind of exchange students, because that place is going. It's not only just to treat patients, but it's going to be an academic excellence too. So in that way, both will be benefited. It's like when I came here, I saw some patients that I didn't see before, because the demography is different here, different type of patients, and there are also different type of patients that you can see back in my country or in other countries. So it's good to have knowledge, experience. In that way, it can also help in both ways. Yeah.
I was worried this table was too quiet. We needed a question. Yeah.
Careful what you ask for that. This is probably a bit of a candid question. Megan was speaking earlier a lot about kind of the public health infrastructure approach, if you will. And I think that a part of a lot of that is that with infectious disease, there's you can prevent it almost outright with the proper interventions and so forth. But the same can be said with trauma. With there being interventions that reduce, obviously what I think what we're working on is more secondary, tertiary intervention. What, I guess from a public health perspective then, could primary prevention be as far as intervening here? Because if that bottleneck is continuing to widen, growing population, expansion, and so forth, is there anything that the organization could do at least to try to provide, data or information or things like that? Because in truth, public health is political, maybe not partisan in sorts, but in nature that it will require political discourse to address all of the underlying issues that are leading to these traumas and so forth.
Yeah, that's great, because really the best way to solve the issue with road traffic accidents is to have safe roadways and have people drive the speed limit. And that's, if you look on that WHO site about successes, it was like in 2015 or 2010, they declared like road traffic accidents like a worldwide problem. And so it's recognized by the world, but they've all the targets they set like back in 2010 to reach in terms of road traffic accidents, they haven't reached. It's such a difficult problem to solve because everybody wants to progress and they want to progress as quickly as possible, and that unfortunately seems to eclipse safety. But in our charter for the International Orthopedic Trauma Collaborative, we have written it in such a way so we can do public health. It's just I don't do public health. But if somebody wants to get involved and run public health, they are more than welcome. But no, that is a huge key component. Did that answer your question?
I think you hit it on the nail. It's political, it's economical. When I came to the United States, it was early 2001 to be perfect. I drove there, everything was right, like you drove right, stop light and everything, and move forward. I went 15 years later, I felt like I was in a different country. Because we used to make a joke about how Indian street or places in Nigeria, how they drive, it was so disorderly, and it became a little worse. I think the way I see it is, especially like where the capital is, the population has flock to the capital for many different reasons. And unfortunately, some of the roads are made in such a way that they didn't have the mindset to think of the people who were not driving, one, and the whole change of economy. People just want to get theirs, and they, they drive hastily, and people who walk don't follow rules if there are some. And I think there has to be a change from the top, in my view, to actually be very strict on road traffic, lights, how you drive, and so forth, because it's very difficult to enforce at a small level. Sometimes you see places where yeah, it looks good, but then you go to other places, they drive crazy, people jump, and I think they build highways sometimes. You have to go so long to actually be able to cross. What do people do, including myself, jump over like some of the videos? So it's a much bigger problem to be addressed just at public health level. It has to be at the top, in a political and economic level.
Anybody else? Thank you all so much for coming.